These are ulcers, and this one is right near the pylorus. This one's someplace in the stomach. So these are gastric ulcers. So what problems might this person develop in the future? What might happen to them because of this? So it could perforate. Sure, if you don't heal an ulcer, it can erode through the wall of the stomach. Fortunately, the stomach has a nice thick wall, so it doesn't erode through very quickly, but absolutely, perforated ulcer. Bad thing. Dr. Mulholland next week will talk to you a little bit about acute abdomen and perforation. Anything else? Hemorrhage, sure. The stomach is extremely well vascularized. If you remember from anatomy, there's at least 4, 5, 6 little arteries in there. And you have to have high blood flow to the gastric mucosa to protect it from eating itself. And when an ulcer erodes into one of those little arteries, you have a voluminous upper GI bleed. You'll get some nice pictures of that in Dr. Paraka's lecture next week. Remember, arteries are under arterial pressure. It's like a fire hose. Okay, so it can perforate, it can bleed. What else? Yeah, so presumably this patient came to you with some symptoms. Sometimes these are incidental, done for another reason, but they can certainly develop pain, they can have worsening pain, they can certainly have chronic pain. Okay, and why did this ulcer occur? Patient says, Doc, why did I get the ulcer? Okay, so there is some factor that leads to ulceration, and we have to admit we probably don't know all of them, but certainly taking nonsteroidal anti-inflammatory drugs. So when you're taking a history from this patient, asking about all the over-the-counter drugs they take is pretty important. Why else might they have gotten it? Yeah. Is their stomach infected with Helicobacter pylori? It's very common, but not everybody has it. And how can you prevent future problems and ulcers in these patients? Yeah, if you cure the H. pylori or take away the nonsteroidals, you may prevent future ulceration and future problems. And we know that once somebody has shown us they're going to develop an ulcer, they have some other factors that make them the one out of however many who gets an ulcer with these factors. They're going to get them again. Okay, what's the other element that you need to make an ulcer? You need acid, yeah. And acid, once we developed effective drugs, turned out to be one of the elements that's the most easy to manipulate. So you've got several ways of treating to heal the ulcer and preventing it. Okay, one of your colleagues has developed epigastric pain. She thinks she has an ulcer. She's been to the first lecture in this sequence. And how would you determine whether she has an ulcer or not? I mean, take a history, epigastric pain. Not all epigastric pain is ulcers. How would you figure out, does she have an ulcer? Okay, you can look. And what method would you like to use for looking? Okay, so endoscopy works really well because this is a lesion in the mucosa. It's not a lesion that's hiding, it's visible. Any other way you can think of to look for an ulcer? Yeah. Okay, so the urea breath test answers what question? What does it tell you? Yeah, so the urea breath test tells you whether she has H. pylori or not. Does that answer the question of whether she has an ulcer at this moment? So what question does it answer? If you find out she has an ulcer, it gives you one of the reasons she might have gotten it. And sometimes I think when working on patient problems, it helps to break down the different questions you have and say, what question am I answering? What are my tools for doing it? So the urea breath test is a great way of saying, does she have H. pylori, which could be a causative agent in getting an ulcer? Any other way you can look for an ulcer other than endoscopy? Yeah. Yeah, you can use radiologic studies with barium. Dr. Al-Hawari next week will show you a number of examples because the barium will fill the crater of the ulcer if you do it the right way. And that's how ulcers were identified long before we ever had endoscopy. Nowadays, in this country, endoscopy is so widely available, that's usually the first choice, but the other is always an option. What else could you do at the endoscopy besides just look and see the ulcer? You could biopsy it, and what are you biopsying it for? Why do you want to biopsy it? Okay, actually we actually biopsy the normal mucosa next to it to look for H. pylori, because when you have an ulcer, the tissue is so disrupted, you may not see the pathologic changes. And what you'll also find out when you do pathology is there can be malignant ulcers from cancers. So that's another thing you could look for. Okay. You have a patient who comes to see you in geriatrics clinic. So this is obviously an older individual. In taking a history, you found out that he had surgery for stomach ulcers back in 1963. He thinks part of his stomach was removed at the time. So ulcer surgery dates back to the late 1800s. The first H2 receptor antagonists, cimetidine, was released in about 1978, 79. I've been around long enough, I remember the advertisements. So prior to that, we didn't have great medical therapy for ulcers. So the surgeons developed operations. They developed operations to both get rid of an ulcer, but more importantly, developed operations to prevent an ulcer. So what can you do with an operation to prevent somebody getting future ulcers, recurrent ulcers? Okay, you can do a fundoplication, and what does that do? Okay, so fundoplication is a wrap around the lower part of the esophagus to tighten up the lower esophageal sphincter. What does that improve? Because we do those operations. That improves acid reflux. Okay. And so it can certainly make your acid reflux a lot better. What operation can you do? And it's a great answer for that one. Good. Glad you brought it up. But what operation can you do to prevent getting gastric or duodenal ulcers? Take out? Okay, take out the duodenum. If you don't have the duodenum, you can't have a duodenal ulcer. That's true. Actually, that is extremely technically difficult to do, so it was the one thing the surgeons decided not to try. So we didn't have acid-reducing drugs. We didn't know about H. pylori. We did know that the stomach made acid. So how can you attack acid production by the stomach? So you can take out the whole stomach. That works. You don't get gastric ulcers. And depending on what you sew to what, you may not get duodenal ulcers because you've gotten rid of acid. It happens that that's a technically more demanding and difficult operation. How else can you get rid of acid? Get rid of the antrum. Why do we get rid of the antrum? Okay, because the G cells are there, and they're one of the big stimuli to acid production. It turns out because the duodenum is retroperitoneal structure, again, anatomy is key here, it's difficult to sew and mobilize. But the antrum is free-floating. And you can actually whack out the antrum and sew the stomach to the duodenum. That's called the Billroth 1 operation. Theodore Billroth was a surgeon in Vienna. And on Sundays, he played chamber music with Brahms. All these little bits of history. So you get rid of the antrum, you markedly reduce acid secretion. Is there another way to reduce acid secretion surgically? Cut what? Cut the nerve, vagus nerve. So vagotomy is also a nice way to reduce acid secretion. That may have other complications, and one of them is that when you cut the whole vagus, the pylorus doesn't open. What happens to you if the pylorus doesn't open properly? You eat a meal and what happens? You vomit it up. So the surgeons learned very rapidly that if they did a vagotomy, they had to open up the pylorus. They'd cut through the muscle and just open it up. So it's called a vagotomy and pyloroplasty. So a V&P, vagotomy and pyloroplasty, would reduce acid secretion, would reduce ulcers. An antrectomy, which is technically fairly easy to do, would also do the same thing. And you will still see these kinds of operations. Now, this is the actually advanced Billroth operation because it turned out to be technically easier, which is a Billroth 2. And you will see patients who have had these. So in the Billroth 2, you cut out the antrum, but instead of trying to stretch the stomach down to the fixed duodenum, this whole part of the duodenum is fixed in the retroperitoneal space, and there is pancreas here, which you do not want to mess with. There's the portal vein, there's the hepatic artery, there's the bile duct. You do not want to mobilize that area unless you have to. But jejunum is very easily mobilized. So you can bring up a loop of jejunum, and now the food comes down the esophagus into this nice big gas fundus and down into the jejunum, and the pancreatic and biliary secretions come up this way. So this is a classic Billroth 2 operation. Worked very well to prevent recurrent ulcer disease. And this is technically easier to do and get people through it without complications. Now in this case, they usually also did a truncal vagotomy as well, just to continue to reduce acid. Now, can you think of any problems that might occur in someone who's had this kind of operation? Yeah. Okay, so you might have problems with absorption. And why would that be? What does the duodenum contribute to absorption? You got lots of bowel, actually. That's why we can do all these bowel operations. You can cut and paste the bowel a lot. You've got a lot of reserve. But the duodenum has some very specific functions. Iron is absorbed in the duodenum almost exclusively. And what's there in the duodenum that's required for absorption of nutrients? Bile and pancreatic juice. Now, it turns out those can trickle down here and mix pretty well, and because our bowel has a lot of reserve, people would get away with this operation. But they tended to be a little thinner. It wasn't bariatric surgery, but they tended to be a little thinner. But those are things that in some people could develop. Now, you're also taking whatever gastric acid is left, because you don't eliminate gastric acid, and you're dumping it into the jejunum. What happens when you dump acid into the duodenum? Pardon? Yeah, it's neutralized. And how is it neutralized? So there's pancreatic secretion of bicarbonate. And in the wall of the duodenum are glands called Brunner's glands. Remember those from last year? They also produce a lot of bicarbonate. So there's a lot of neutralization of gastric acid here. The jejunum spends its life in a fairly neutral pH solution. It is not used to a hydrochloric acid at a pH of 2. So what happens if you dump some, not a lot, but some hydrochloric acid here into the jejunum, which is not used to seeing acid? It can't protect itself. It could perforate. You get ulcers. So you can actually create ulcers right in here. Fortunately, it doesn't happen to most patients, but it can. So just by looking at the physiology of that system, you can predict the consequences of surgery. Now, overall, most people do fine with this operation, but you will see some who come in with complications, and these are this kind of complications. And that's Theodore Billroth, picture of him. Okay, We have a 75-year-old woman who comes in concerned that she may have gastric cancer. She has a family history, she says. She's heard about it in the news. She read something in the New York Times science section. She was reading a lot, sometimes too much. She went on the internet and they talked about all these horrible things of gastric cancer, and she's very concerned about gastric cancer. How would you find out if she has gastric cancer? Yeah. Well, first of all, you have to decide, is there a legitimate reason for doing any tests at all? That's always the first part. There are some patients you just can't negotiate with. Say she has some symptoms or something. So it's an epithelial-based cancer. So it comes from the mucosa. So it's an adenocarcinoma. So it is visible. Most of it is visible in the stomach. So again, endoscopy would find it. Anything else that could then find it, other than endoscopy? So, and you'd want to biopsy it, because if you see something, you want to find out, is it a cancer, is it inflammation? Anything other than an endoscopy that could do it? Yeah, so just like you can use a barium radiologic study to look at things in the lining, this either erodes into the wall or it protrudes out of, and you may well be able to see it on a barium study. And we'll be showing you examples. And then you can biopsy it when you're there endoscopically to prove, is this malignant, is this inflammation? Okay. We have coming up in about a week and a half the annual food extravaganza called the Super Bowl. And you're now a second-year medical student, so your family considers you the fountain of all medical knowledge. And you don't want to disappoint them too much. But you do know who to call for more advice. That gets you a long way. Your uncle pulls you aside and tells you he always gets bad heartburn from the salsa that you serve, and he loves it. He wants to know from you how he can avoid getting heartburn when he eats the salsa and chips at the Super Bowl party. So what do you tell him? Other than not eating the salsa, which is answer number one. He's not finding that an acceptable answer. The lifestyle modifications aren't going to work here. Yeah, so you can give him an acid-reducing medication that he takes ahead of time. And one suggestion was Prilosec, so that's a proton pump inhibitor. Is there any other medication you could give him to prevent him getting heartburn at all? Yeah, you give him an H2 receptor antagonist. And if somebody just has occasional heartburn, those probably work about equally well. Your cousin, however, decides to go ahead and gorge on a pizza and pulls you aside because he's having terrible heartburn right now. He made it to halftime of the game and now says, I can't stand this anymore. What would you do to make him better? Did I hear an endoscopy? That would be an interesting one. We'll give you a portable instrument to take home. That might cure him of gorging on pizza. Okay. Yeah, so you want something that works immediately. Antacids work immediately. So if you want to take care of an episode of heartburn right now, your best tool is an antacid. Again, lifestyle changes are a great suggestion. They may not be accepted. Okay, your grandmother overhears all this. This really is the big family gathering. And she is really upset that her doctor has told her she's susceptible to ulcers and she can't take her arthritis pills. She really has pretty significant arthritis in a number of joints, and she wants to know why her doctor took her off her arthritis medications and what you can do to solve her problem. So, why do you think she was taken off the arthritis medicines? What medicines do you think she was on? Yeah, she was probably on an NSAID, and she got epigastric pain. Now, we don't know whether she had an ulcer or not, but she got epigastric pain. So anything you can suggest to her? Okay, so she could switch to celecoxib, which, because it's a COX-2 inhibitor, will give her arthritis some success and not cause as much stomach problems. What else could you do? Yeah, you could give her a proton pump inhibitor at the same time. That will also protect her stomach. Now, we don't know from the history we have whether she actually had ulcers or whether she had just dyspepsia. But that combination will certainly prevent ulcers. It may prevent some dyspepsia. Okay. You have a woman who went to the Mayo Clinic to be evaluated for a variety of symptoms and was told she had the Zollinger-Ellison Syndrome. Then she comes back to you and says, I now want you to take care of me for this. And this is due to a gastrin-secreting tumor, which is uncontrolled and doesn't stop secreting gastrin. So what kinds of problems is she likely to develop? She has uncontrolled gastrin production. And we do see these patients, by the way. So you can get hyperplasia of what part of the mucosa? Okay, what's gastrin doing? What cells does it stimulate? So parietal cells. So you get hyperplasia of the parietal cell mass, which is mostly in the fundus of the stomach. What happens if you have overactive parietal cells going all the time? The Energizer Bunny here. Yeah, ulcers. These folks have horrible ulcer disease because they're making enormous volumes of acid all the time without regulation. So they get gastric ulcers, they get duodenal ulcers, they can even get ulcers way down in the jejunum because this overwhelms the bicarbonate neutralization. So they get really bad ulcers. What else can they get? So we got acid in the stomach, we have acid in the duodenum. Actually, they don't get stomach cancer that much. I think it's because they're eroding away the mucosa so fast. And probably because they don't, if you don't treat them, they may not live long enough. So they get all the complications of ulcers. Bleeding, perforation, strictures, things like that. Where else is that acid going to go? It goes down. Where else can it go? Up. So that would give them what? Yes, they also often have horrible heartburn. Okay? Now, and I'm stretching here. I know it's been a year. I know they're doing GI in the first year now. Pancreatic enzymes. What happens to them when you bathe them in acid? They die. So if you have acid pouring down the duodenum, you're going to eliminate pancreatic enzymes because they will be destroyed. What happens if you don't have enough pancreatic enzymes? You malabsorb. That's a lecture tomorrow at 9 o'clock. Okay. And how could you treat her? A constant intragastric drip of antacids is probably not going to be very practical. Run around with an IV pole and a 1 gallon of Maalox and continuous drip. So what else can you do? Yeah. So this lady's problems are all due to acid production. And if you can get rid of the acid, they actually do very well. These are small, slow-growing tumors. They metastasize very late. If you can get the acid controlled, even if you can't cure the tumor, which you may well be able to do, you can solve all of their problems. And you need something that's really potent, so it's the proton pump inhibitors. Some of the highest doses you've ever seen, but it works. Yeah. Some of them are in the pancreas. Some of them are in the wall of the duodenum. Some of them are in the stomach, but most of them are the duodenal wall and the pancreas, where there's neuroendocrine cells. And there's actually several familial types called multiple endocrine neoplasias, type 1 and type 2, and one of those has Zollinger-Ellison. But you can see it just by itself also. This is probably one of the most common, it's not the most common, carcinoid is the most common, but another common neuroendocrine tumor. And all they do is make gastrin. Okay? All right. So I think we used up our time this morning. We'll continue tomorrow, and let's take a break, and we'll start the lecture on diarrhea at 9:10.